All right. How's everybody's spring break?
Wasn't bad.
Wasn't bad. Anybody go anywhere far or near or did anything fun?
Glamis.
Glamis?
You suck.
If it was Glamis, how long did you spend there?
5 days.
Glamis is the dunes.
Okay,
The
I'm
dunes
like,
over where you went.
Did you go into Glamis or go to North?
Oh, it's Glamis. Not really like Hollow's side. Or not Hollow's, yeah, Buttercup side. Too far away from everything.
Anybody else do anything fun?
St. George.
St. George. What's in St. George?
Dixie College, had to go get, 22 years ago, I had to get all my course descriptions to get, credit on my, so all my credits will transfer, even though I have an associate's degree. So I had to go in
get
the
your
basement and archive.
I was gonna say, they don't have
the
things
ancient
like
archives.
internet and email there?
Well, I was already up there,
Oh,
kind of
okay.
things, but
Okay.
I grew up in Fredonia,
Okay.
the other big city up there.
Oh, cool. Good times, good times.
Anyway,
Everybody get to chill and just take it easy? Everybody busy?
Cleaned up my grandma's property.
Clean up your grandma's property, that's always good. I went to Tucson for a couple days with the family, went to the Jump Street. Should've brought some video, I have video of me doing back handsprings and back tucks with the kids.
My brother-in-law works there.
Really?
My sister just got married this weekend.
Cool. Then I went to Pot of Gold Festival, music festival at Tempe Beach Park. It was fun.
Is that like folk music or what?
No.
It was bands like Korn and Chevelle
Pot of Gold.
and Godsmack. So it
All
was
the
good
good
times.
stuff.
Yeah, good times.
You were trying to fill
Yeah.
20 years younger or 10 years younger.
And then I had meetings for Airvac on Wednesday, so it's really good. Good times. Any questions about anything? Everybody looks like I only had a few people that are in question about passing the class after 13th, but most people, actually everybody that's here is in good favor, so.
Do you have our tests?
That was a
that we can
long
look at?
night.
I do.
I've been
Hey
telling you
Justin,
today.
where are their tests?
What's that?
Their tests, the tests for the 14, 18?
You had those.
I have.
I gave them back to you.
That's right. Could you do me a favor and go there right by somebody's printer?
Sure. I'll go grab them.
We'll go through those. Any other questions?
So we totally start over online.
Oh,
Unless you have
yeah.
something,
So it's already open. It's opened up
Okay.
it opened up Sunday night at 11:59 or whatever.
because you're on top of things like that.
Or you can automatically set it up. So either way, I set it up at the beginning of the semester to do that. How to do that for part of the planning for the syllabus. So we only have a couple modules left. So usually a couple days prior to everything closing, I'll open everything back up. So you can't submit any new assignments, but you can at least go through and look at all the PowerPoints and all that stuff. So some things that came up that was a common problem during when I was doing some grading, and it was our labeling. And one of the problems like give 40 milligrams of Tylenol, 160 per 5 mLs. Okay, so you would do the math. 40 milligrams times 160 milligrams, 5 mLs. What is that? 1.25 mLs. But then someone would do this, 1.25 mLs, or they would do, actually, that wasn't the big problem, except if I did this. What is 1.25 mLs of 160 milligrams over 5 mLs? So they would do the math, 1.25 mLs, 5 mLs, 160 milligrams, and they would do the math and get 40 milligrams, but then they would do this per ml. Is that correct? No, and it was so common, it blew my mind how common it was. This, what is this? What am I, when I put that 40 milligrams per ml, what am I saying that is?
It's 40 milligrams per 1 ml.
Yeah, that's a description of a dosage strength, right? That's a description of a concentration. We already have that set concentration. 160 milligrams per 5 mLs is not the same as 40 milligrams per ml. The answer is 40 milligrams, okay? They are two separate things, okay? That will get you in trouble when it comes to calculations for these next two modules. The next two modules include IV titration rates, LCU medications, and weight-based medications for pediatric patients with trips and all that kind of stuff, process. So, if you do that, that will totally mess up your calculations and answers, because sometimes we have to do some math and then do some more math before we finally get the next answer. So if you have an extra unit label on there, that will make it so your math is totally wrong, and dimensional analysis doesn't work out when you start jumping to the next step, okay? So make sure you understand that. If you are given a concentration, that's your concentration. We're looking for an actual dose here, which is 40 milligrams, not a new concentration, okay? All right. Just one of the things I saw while grading. Purple's not a good color for that board. These are the in-class.
Oh, over spring break. Like,
Some common ones that were missed were inappropriate rounding. If we were going to be using it, so anything over, remember we talked about it in class, anything over 1 ml needs to be rounded to the 10th. So, just a reminder. They were looking at me funny. Like they're scared.
Honestly, I was waiting for like a 5 out of 25.
What's funny to me is some people who have a hard time showing their work on the computer showed their work perfectly fine on this test, which tells me that you're perfectly capable of doing it. If you were wondering, I noticed those kind of things. So these are mine. I'm just letting you look at them, I keep them on file. So
I want these back.
yeah, so take a look at them. If you have any questions, we'll address them. Otherwise, today on your syllabus it says lab day. Part of this lab is understanding medication for insulin and mixing medications, like with syringes. So what we'll do, so that people in computer land can have a lecture. We're going to lecture first and go through chapter 19 and 20 together. And then what we'll do is we'll turn off the computer, or we can leave it running depending on what time it is. If it's 2 hours long, then we don't want to have someone have to watch 2 hours. But then I'll pass out these little packs. Everybody gets one, and we'll actually do some, you know, the shade in the syringe for the right answer. We'll do some of the math, and instead of shading in the syringe, you'll actually mix the medication and draw it up and pull it up in your syringe and have it set to the right amounts. Okay? Then we'll do the same thing with some insulin. We'll actually go over some insulin. Okay. Any questions on your tests? If you're nervous to bring it up in front of the class, that's fine too. You can come see me.
I got the time one wrong. Don't know how to do that one.
Okay, what was the time one?
Okay, yeah.
My view started at 3:10 a.m. is to be completed in 12 hours and 30 minutes. Determine the completion time in traditional time.
Okay, started at 3:10 a.m. and supposed to go home.
12 hours and 30 minutes.
And write it in traditional time?
Yes.
Okay. So, what is 3 plus 12?
15.
15.
40.
Okay. What is 10 plus 30?
40.
1540, right? Would be military time. Remember you add minutes and hours separate? So 1540, but we need that in traditional time, so what would be traditional time?
3:40 p.m.
Oh, so that's how you want it, so sure on work.
You can show it, or
So can it be called standard time as well, or is it traditional time?
traditional standard, it's all the same.
Okay.
Unless I said 24-hour
So-
format, or military time, or
Okay.
computer time is,
Computer time.
that's it. Computer time is military time. That's per the book. I've never heard it called computer time until I took this class. So. You could have done it, you could show your work this way. Okay. But common sense tells me if I have 3 a.m. and I add 12 hours to that, it's going to be 3 p.m. Okay. So. Any other questions?
Morgan has one.
Morgan, ask it.
Okay, I don't know, I didn't understand the 8 pounds, 12.2 ounces to kilograms.
What number is that?
Over 16. That's how many ounces are in a pound.
Okay, let's do it really quick.
Do 4.2.
8 pounds, how much?
12.2 ounces.
And 12.2 ounces. Okay, so what is my conversion factor?
12.2.
No,
2.2.
2.2 pounds. Oh, I'm dyslexic today. Okay, let's start over that. 2.2 pounds, there we go, equals 1 kilogram, right? Is there any ounces in there?
No.
No, so I have to do something with these ounces. So what I need to do?
12.2 divided by 16.
Yeah, and what does that do?
Converts it into a decimal.
It makes it all pounds. That's what we're trying to do. Because there's 16 ounces in a pound. So 12.2 over the whole of 16 is going to make it pounds. Okay? So then 12.2 divided by 16 is
0.7625.
right?
And then I just rounded it at the
So
end.
what would be my rounding?
I waited until the end round, and it still got me the right answer.
Okay,
It's 0.8.
that's what I just did. So 8.8 pounds times 2.2 pounds, times 1 kilogram divided by 2.2 pounds. Is dimensional analysis for that.
3.
Should be 4 kilograms.
Round afterwards.
Okay?
Yep, makes sense.
Does that make sense then?
Yeah.
I still got that stupid song in my head.
I was humming it on the way over to your
4 or
office.
5 seconds from Friday.
My kids have been singing that all
And
weekend.
it's the stupidest song. I don't even get
It
it.
doesn't make sense, none of the lyrics.
I don't get it. Anyways. Okay, any other ones? We're all good in the head? Okay. So we'll both pass those out to the outside. The other outside. Pass you that. Got you. Yeah. Good, awesome. I've been like the OB king when it comes to flights. I have flown more OB flights in the last 2 weeks than I have flown in like my whole AirVet career. Maybe is that gonna be too close? God, it's probably good enough.
Isn't that bad? How many flights do you have?
I had 4 flights that are just OB. Because we have an actual specialty OB team that comes in from Phoenix to do the high risk stuff. If they're busy and you're maternal certified, then you can do the OB flights. So and those are my least favorite because I'm an adult ICU nurse, not a maternal nurse by trade. So I always have to rack my brain.
A little bit of stress.
Yeah. And then Friday I had the worst call I had in a long time. The patient kept trying to die. I hate that.
What were they thinking?
I know. It's like he didn't think about me for sure. He
Man, I'm gonna make this guy do his paperwork.
yeah, he's like, I'm gonna make him chart for 3.5 hours for a 25-minute call. That's how long it took. He really sick old man. And they were shipping him, not from here actually, from a different hospital. We had to fly to the hospital with the patient to University Medical Center, which now Banner Good Sam is called University Medical Center Phoenix, and Banner University Medical Center Phoenix, and then Tucson UMC is now called Banner University Medical Center Tucson, if you guys are wondering. Banner bought them all out. So.
I'll remember that one.
Yeah, but it was he was very unstable, and I swear that the nurse played me because she had marginal blood pressures on the monitor, on his monitor. So I'm like, that doesn't look very right. And he's like, oh, I'm having a problem with that all day. Let me just take a manual pressure, pump, 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 pump. Oh, 120/80. I'll see you guys later. Because if it's too stable, they can't fly. Unstable, they can't fly. So I think he knew that the patient was too unstable, but I trusted his blood pressure. Till we were loading in the helicopter, and I got a blood pressure of 30/10. Yeah, Michael, that's not really consistent with life. So, yeah, so pushing all kinds of meds. We almost ran him back into the hospital and coded him. So we got him stable, put him in the helicopter, and then when we're flying, he tries to do it a couple more times.
You flew him to Tucson?
Yeah, just 25 minutes is all the flight was. And I was
It's a
like,
long 25 minutes.
it was the longest 25 minutes I've had in a very long time. Goodness.
When you lose them, do they keep coming back and then you lose them again? And then if they come back, you lose them again?
Yeah, depending on the situation. I've had patients go away and not come back. So, thank goodness we kept getting him back. But he when we got there, they could tell me and my partner were super frazzled. And so,
Was it you and Mark?
yeah, and so it was me and Mark Kimpton, the paramedic teacher. And he asked, is the patient code? And Mark says, well, he never coded, but he was playing with the code button a lot. He put his finger over it and playing. Warming it up. Gosh. And so when we landed, finally we had him stabilized. We took him into the hospital, and we're all happy, proud of ourselves, but I didn't chart one thing the whole fly. Usually I chart the whole fly on the paper, and the medic does all the patient stuff, and I do all the paperwork while we fly. We were both so busy doing things that I didn't write one thing down. So I had to sit there and write it all down while standing at the bedside. So it made me feel better because I handed them over to them. They're looking at us like, well, this patient's perfectly stable, you know. So I'm like, no, I'm serious. This was the crappiest flight ever. And I didn't say crappy, I promise. And right like 10 minutes after I dropped them off and I was sitting there doing paperwork, all of a sudden I heard the nurse call, hey, I need a little help in here. And all the doctors run in there and everything. He tried to do it again, except they had 8 people helping them. It was just me and Mark by ourselves in the back of the helicopter. So, anyways. So, reconstitutions and solutions. When you reconstitute, it's very important that you understand the type of diluent that you're going to be using, and a lot of medications are actually specific on what kind you use. The amount that you're supposed to add, and most medications are specific. If you want a certain concentration, they will tell you how much to add, so you'll get the right concentration. That way you can do the right math. Also, in your fancy drug books, when you guys get into nursing school, if that's what you're doing, I'll even tell you how long this medication is good for once it's been reconstituted. Those are all important things. And that especially the directions for storing the medication after mixing. Some medications, after they're mixed, are only good for 60 minutes. And then they start to break down chemically and start to lose their efficacy. So that's why it's very important that you read the label. Seems like common sense, but not always. Some medications are supposed to be mixed with bacteriostatic water. Some are supposed to be mixed with normal saline. Some are supposed to be mixed with D5W only. Okay, so when you mix, you want to make sure that you put your initials, or if you access a multi-dose vial, you put your initials on them. The date and time that it's prepared, and the expiration date and time. So that way, if somebody's using that vial after you, they know all the specifics. Insulin is the most common multi-dose vial that we label and put expiration dates on in the hospital setting because we keep them for a length of time. And that's actually one of the things that state, when they come out and inspect hospitals, they inspect all your multi-dose vials for open dates, signatures, and times on the bottles. Otherwise, you can get dinged as a hospital. So, make sure that you understand, though, if it's a single dose and you're going to use all of that medication, you squirt your 2.2 mLs in there and you pull out the 3 mLs of all the medication and it's all gone, and you toss the vial. Do I need to sit there and write on my vial just because I'm going to be tossing it in the trash? No. So don't waste your time. But if it is a multi-dose, make sure that you do everybody a favor and write on there. Also, I do it all the time when I have narcotics or something like that I am going to be multi-dosing from. I keep little sterile caps in my pocket. So once I mix a vial of like morphine or vecuronium or some kind of medication that I might use a couple times from the same syringe, I have a sterile cap every time. That way it stays good. But what I put on there is I actually label it. I keep a Sharpie with me in the helicopter, and I keep a Sharpie with me in the bedside in the ICU. And I'll write on it, morphine, 1 milligram per ml. And then that way they can look at it and say, okay, when they know exactly if somebody grabbed that syringe, if I said, hey, give 10 milligrams, they could grab it and say, oh, look at it and say, okay, I need to give 10 mLs. So that's why I do that in the hospital setting. It's happened more than once where I've had emergency situations, and I've had all my meds there labeled and ready to go, and anybody can pick them up and grab them and use them from that point. So, but you just have to understand that you have to trust the person that mixed them. So if you wonder that, if you are a person, and it's good practice when you're doing mixing of medications, that you watch 2 people do it at the same time. And for some medications, it's required in the hospital setting because you have to sign off on it. There's 2 types of labels that you'll see, and we'll go over these a little bit, but there's single dose. So the label will just give you a one-time, like 2.2 mLs to this 300 milligrams to get a 100 milligram per ml strength. And you'll get 3 mLs, right? Based on the expansion of the medication when it gets wet and those kinds of things. Then there's actual, like penicillin's one of them, where it's multiple strength, because we'll give it different routes. I'm going to be giving it intramuscular. I'm not going to be giving the same concentration. I'm not going to give a 100 milligram concentration or a 1 million unit concentration. I am in 10 mLs, right? because that's a large, excessively large amount to be putting just in the muscle. But I can give that dose in a 1 ml solution. So what it will tell you is if you want certain different concentrations, and we'll go over a label that looks like this. It will tell you different mixing instructions for each concentration that you're shooting for, based on the dose that you need to give and the route that you're going to give it. All right, so this is how to mix medication. So I'm going to pull this up on the big screen so everybody can see it. See, I'm going to make it your guys' horrible day too by making you listen to that over and over again.
It's really zoomed in.
Autofocus. Come on now. Let's try that one more time. There it is. Okay. So you have your medication, and now on the screen there, it was oxycillin sodium on the PowerPoint for that first PowerPoint. And we have our practice powder that you guys will be using today. You notice it's got powder in there that you can see. Focus. There it is. Okay. Our syringe. We're having multiple syringes actually that you'll be playing with. 10 cc, 3 cc, and a 1 cc syringe. And then a mixing needle. Okay. So, anytime that you're going to be doing mixing, you want to make sure that you have the right vial. So this says 2.7 mLs. So what's going to be my best syringe to use? 3 ml, right? Especially with it being 2.7. 10 cc syringes most of the time are in 0.2 increments between mLs. So am I going to accurately measure 2.7 with the 10 cc syringe? No, it'll be 2.6 or 2.8 if I want to be accurate. So that's why we're going to use our 3 cc syringe. So when you're opening them, you just want to make sure that you stay sterile. This area right here is sterile. The green hub, that is sterile. This tip right here on the syringe is sterile. So you have to make sure that you do it so that it is sterile. So that includes pulling that out. Am I going to touch that tip on anything?
No.
No. Let's try it on the screen. See how I'm pulling it out? Have I touched anything yet? No. Now I still have maintained sterility of that needle. That way I'm not going to poke somebody with an infected needle. Okay. And with alcohol wipes somewhere, I thought I saw them. Watch this sentence. So we would take the top there. This has been accessed a couple times because it's been in the lab before, but clean the top. And then we want to inject air into our, holding just the plunger end and not touching my shaft of the plunger. And pull back 2.7 mLs. Okay. And put air into my bad practice, don't do it like that. Do the scoop method, but why did I put air into my vial?
So you can draw 2.7.
Right, so it creates a positive pressure so that when I pull 2.7 mLs out, then it goes back to normal pressure. If I have a multi-dose vial especially, and I create negative pressure, and I have a little tiny microscopic hole in the lid, and I have negative pressure, where's it going to go? The air going to go? It's going to create a vacuum and it's going to go into the vial. Okay. And if I have a little bit of bacteria that's still on top of my vial top, and I have negative pressure sucking that down into my vial, repeated attempts of just creating that negative pressure, I can make my vial go bad early. Okay. So I would clean my top, or I would do it right then. You can put your 2.7 mLs in and then immediately flip it back over and pull your screw point. It's hard to do at an angle there, so I'm gonna pull it up out of view. Okay, 2.7 mLs. I'll take my lid off of this one, scrub that with alcohol, and then inject it. Okay. Like I said, scoop, don't recap your needles like I just did, but it's hard to do it on the flat top underneath the camera. Okay, so if you notice here, I got some on the top, so I need to put it up there. Do I want to shake my medications?
No.
No, swirling is the best method. Some medications are protein based, and the second you shake them, they turn all into solid foam. Can I draw solid foam up on my syringe? No. And all that powder is suspended in the bubbles, and you don't get the right dose. So swirling medications. Some medications that come to mind that we swirl or rock instead of doing shaking is like snake antivenom. That is the worst. You have to be really careful with that because it'll foam all the way up, and then your patient doesn't get the dose. So, all right. So we added the 2.7 mLs, and then we have a 500 milligram per 3 ml solution. But wait a second. I put 2.7 in there. Why does it say we have 3 mLs?
You had 0.3 mLs of dry solution.
Exactly. Okay. So you have to, when you put it in there, then you have to use the label's concentration for your mouth. Okay? So if it's available in 1 gram powder and it tells you to add 2.5 mLs to yield a 3 ml solution, what's my concentration? 1 gram per 3 mLs, right? That's my new concentration. That's what I have to work with if I do my math. What if I want to give a 200 milligram dose? Is that going to be hard to work with? 1 gram for 3 mLs? I'm going to have to use a 1 cc syringe and draw down to the smallest possible level, right? Or, common sense tells me if I have a larger amount or more dilute solution, I can be more exact with the larger volume. So if I mix that, then after I took the 3 mLs and I put it with 7 cc's, what will I have? A 1 gram per 10 ml solution. Then I can just give 2.5 mLs and have an exact measurement. It's easy to work with. So just remember, those are some of the tricks that we do if we're giving small doses from high concentrations, because 1 gram per 3 mLs is definitely a high concentration. But what if that was Rocephin, medication that we give commonly in a 1 gram dose? And we give it IM very commonly. Do I want to change that at all? No, because it's going to be needs to be a smaller volume to go into muscle for the intramuscular injections. Just make sure that you choose, when it has a multi-dose or multi-strength vial, you choose the right strength for the right concentration for the way you're going to be administering it. Okay? I think 1 gram and 3 mLs is great to put in an intramuscular injection, but that would be horrible to put in the vein. Okay, it could tear up your vein really quickly and have your vein go bad. So then we'll mix that 1 gram and 50 cc's. Now we have a solution that is appropriate for venous access. Okay, so just make sure that you understand, and it's all in the books, and I know it's overload right now, but it's in your book, so I have to mention it. But you'll get tons of this in school. You'll have multiple 2-hour labs to go over medications and concentrations and routes of administration and those kind of things. So this is just a little touch on it. So just remember, consider the route, consider the concentration and strength that comes closest to what you have ordered. Okay, so like I said, if I have 1 gram and 3 mLs and the doc ordered 125 milligram dose, then I might want to mix it different so I can get that 125 milligrams easily, right? Just a little bit of chemistry, something you should have learned in Chem 138, but your solute is a concentrated, whether it be solution or powder, okay? Your solvent is the diluent, that's what you add to it, and then your solution is the combination of the two, okay? So your medication is the solute, your D5W, your normal saline, your bacteriostatic water, your bacteriostatic saline is your solvent, and then the combination of the two is the solution, or that medication dosage strength, okay? So this is a label here. Look at, right here on there it says, dosage and use, constitute 100 milligram per mLs by adding 4.8 mLs of sterile water for injection. So I have 500 milligrams in 5 mLs, or I have 100 milligrams per ml. So when I'm going to do my math, what concentration am I going to use?
The 500 milligrams.
You can use either or, 500 per 5 or 100 per 1. But 100 per 1 is probably going to make math a little bit easier in comparison to the 500 per 5. But they're both fine, and you both, if you have a calculator especially, that's perfectly fine. Okay. But this is the directions that when I put 4.8 mLs in with this medication, I am going to have this concentration. If I put in 5 mLs, am I going to have this concentration? No, I want to have a slightly different one, right? So that's why it's important to put in what's mixed, what says to mix, that way you have accurate calculations. And this is just an idea of what you can put on a label if you are using a multi-dose vial or something like that. It's going to be sitting in the refrigerator that somebody else can access. Here's another one. Kefsol. The order is for 225 milligrams IM. So, how many mLs am I going to give this patient?
2.2.
No,
Yeah. 2.2.
not 2.2 mLs.
Oh, 225 milligrams per 1 ml.
Right.
So
2.2 mLs is what I add to the vial to get a 225 milligram per ml concentration. Okay. So sometimes you get some random concentrations. So that's why you have to make sure you do what's on the label. This is just if we were going to go through the steps, okay, that we already did. And we'll get, the people online will have opportunity to do that in their assignments and go through these PowerPoints in length and look at those again. And for you guys here in the classroom, we will be actually doing those hands-on, so I'm kind of skipping through those. So here's one of those penicillin different concentrations I was talking about here. If you look, all the different concentrations. So if I want a 50,000 units per ml, then I need to put 20 mLs in that vial. If I want 100,000 units per, 100,000 units per ml, then I'm going to add 10 mLs to that vial. Okay. 250,000, I'm going to add 4, and 500,000 per ml, I want to have 1.8. Okay. So that's just telling you how to mix it based on the concentration you need, which would be dictated by what?
the label.
Well, what makes me give different concentrations per dose?
The solutions.
The route, right? The route's what's important. Or the dose that's ordered. If I can do it by dose and make it in one of those concentrations, it'll be easy, right? If, like, let's say it's a pediatric patient and they order 100,000 units per ml, and my order's for 100,000 units, and I'm going to use the 1 ml, the easiest way to get there. Okay? Here's my favorite. Tazidine. It's a real medication. I didn't make it up, I promise. There's another one called Tazosef. I actually went to, when I got really sick one time in the hospital, they were giving me that medication. I thought it was kind of cool. All right, I'm done like that. But anyways, so how do we mix this one? I'm making everybody turn their head.
4 IM, 1.5 mLs per approved shake load.
Okay, if I'm going to give it IM, what's going to be my concentration?
That'd be 1.5 mLs.
There's a specific concentration on there under IM. Halfway down the IM paragraph.
1.8. Wait.
How many milligrams per ml? That's when I say concentration, I say milligrams per ml. Starts with a 2, ends with 80. 280 milligrams per ml, right? If I want to make it IV solution, then I'll just dilute it with 5 mLs and add it to whatever dilution I need. Okay, that's what it specifically says. My neck hurts already from looking at that. I need to do adjustment over to do this.
That's what I was trying to do. So,
Solumedrol. What's solumedrol? Anybody know? Solumedrol is a steroid that we give for patients in respiratory distress. And the common dose is 125 milligrams. And then, so if I was going to give this patient, I know on his bottom it says solumedrol 200 milligrams IV, but the most common dose is 125 milligrams. So if I wanted to give this patient 125 milligrams, how would I prepare that for them? I'm going to add 8 mLs of bacteriostatic water, right?
yes,
That gives me concentration of what?
62.
62.5 milligrams per ml. So how
you
many
give
mLs?
It'd be 2 mLs.
2 mLs. So 125 milligrams per 2 mLs or 62.5 milligrams per 1 ml is actually the most commonly prepared solution. So yes.
Can you show us how to do this? Or
Please.
just-
Please.
You're waiting to get through these and then.
Yeah, because what we're going to do is we're going to do these on the board and with syringes. So I'm just cranking through this so that way our online people have some lecture time, and then we'll start doing these on the lab. Because we still have to get to chapter 20, which is insulin. So I'm just kind of cranking through so we have some hands-on time. Does anybody else know what solumedrol is given for? In high doses, so 125 milligrams, we give it for respiratory problems, for cord injuries, spinal cord injuries. We give it in high doses because about 50 to 80% of cord injuries are first the initial damage to the cord, but it doesn't kill the cord. It just shocks the cord. And then the swelling that follows in a narrow canal, that swelling, that spot will then put back pressure on the cord and cause lack of blood flow to it. Then it finally kills the cord with pressure, with inflammation. So it's not that the cord is severed, it's just that I've shocked the cord and the swelling has killed the cord because it has nowhere to go. So we give them large doses of solumedrol, hopefully to reduce that inflammation in the spinal canal where the cord sits, so that way we don't have that secondary swelling actually kill the spinal cord, so that it makes it so that patients can recover. So it's depending on what trauma center you go to, they'll do that or not. Sometimes we'll call for it. Anytime we have a spinal cord injury, we have to call ahead to the trauma center we're taking to and say, hey, do you want us to start solumedrol or not? We carry large doses of solumedrol in the helicopter because we do fly on traumas and we're the first responders a lot of times for trauma. So that's why we carry it, just in case the trauma center wants us. The sooner the better. So we talked about that, but we'll just go through it. It said add 8 mLs of bacteriostatic water, okay? Put it in the vial, swirl it around. Now we have 8 mLs of 500 milligrams or 62.5 milligrams per ml. And we'll do some of these on the board. Okay. So the dose was for 200 milligrams based on the bottom, but I made it easy by making 125 milligrams, right? And 62.5 goes into 125 2 times. So that was an easy math doing at 2 mLs. But if it wasn't, we had that 200 milligram dose, then we could do dimensional analysis, starting with our 200 milligrams on the left, and then what would be the concentration or our conversion factor that we would use. It would be the 62.5 milligrams, right?
3.2 mLs.
Right, so if we were going to do this one really quick, we have the order for 200 milligrams, right? And we take that 200 milligrams, and what's our conversion factor?
62.5 milligrams per 1 ml.
Based on the 500 milligrams and 8 mLs. Could I put 500 milligrams in 8 mLs here?
You could,
Yeah, and will I get the same answer?
should.
Yeah, I will. Milligrams cancel. So 200 times 1 divided by 62.5 is 3 point what?
2.
2. Okay. That kind of makes sense. I know we're cranking through it. This is just showing the dose over ordered or available method. I would prefer dimensional analysis because you can use it if you know it now. When we get to the end chapters where it's almost mandatory that you use it, you'll be a pro at it instead of using the formula now. You know, it makes it. I'm making you do hard stuff now so that your hard math later will be easy. Okay. Just remember, this is solution strength. The numerator of the fraction is the number of the parts of the solute. Okay. The number of the denominator is also the number of parts of the total solution. The difference between the denominator and the numerator is the number of the solvent. Okay. You're wondering why I'm mentioning this? Is because we're going to start going into something else here. You sometimes will get orders like this. You need to order a 1/3 straight nutritional formula. This is what we commonly use for patients on a medication called Vivanex. Vivanex is a tube medication or nutrition supplement that we will put in there. It's total nutrition. Comes in a yellow powder that you mix up to put in peg tubes and feeding tubes and all those kinds of things. So based on the patient's tolerance and caloric need, we will mix it at different strengths. Okay, so sometimes you'll get half strength Vivanex, 1/3 strength Vivanex orders. Okay, so we have to understand how to mix that. So based on this, looking at this, we have a 1/3 strength nutritional formula. The top is what? How many parts of the concentrate? The bottom is 3 parts of the total solution. Okay, so 3 minus 1, because we have 3 totals, right? The number on the bottom is the total. So we have 2 parts solvent. So if I was going to mix this, I would have 1 part concentrate with 2 parts solvent. Okay? Some blank looks there. So the best way to do this, I think when I tried to go through this last semester to teach this, I had a hard time my own self wrapping my head around this 5-to-1 or the 1/5 or all the ways that it's done here, especially using this dosage, the DQX method. Okay. So the easiest way that I found is ratio and proportion. You guys remember that when we were trying to figure out ratio and proportion? So let's look at this, okay? And we'll do this one on the board really quick. Suppose a physician writes a wound irrigation, which is usually we'll have like a wound irrigation called Dakin's solution. And so that needs to be mixed and diluted. So wound irrigated with 2/3 strength hydrogen peroxide and normal saline every 4 hours while awake. Okay, so if you do 60 mLs per irrigation and you're going to do 3 irrigations in your 12-hour shift, hence the Q4, right? 12 hours means 3 times, right? You'll need to prepare a total solution that you can use 60 mLs at a time. So when I'm making it, I need to make 180 mLs of total solution, right? So what is my new whole?
180.
180, right?
And 2/3 of
So
the
how much hydrogen peroxide and normal saline will I need?
120 mLs of hydrogen peroxide and 60 mLs of normal saline.
Okay. So here's how you do it. Okay. We decided we needed 180 mLs total, right? And we're going to make a 2/3 solution, right? Does it see how this is adding up? Now we can do ratio and proportion. What does the number on top mean?
How many parts?
How many parts of the concentrated solution, right? So I'm going to have 2 parts of the concentrated solution out of the 3 parts whole. So 180 mLs is my whole, so I can see how many mLs of the concentrated solution I need. Cross multiply and divide. Okay. Right? So now 120 mLs. How much of the, so that's of the concentration. So well, how much do I need of saline to dilute it?
60 mLs.
60 mLs, right? How did we come up with that 60?
Because that's the rest of the whole.
Right, that's the rest of the whole, 180 minus 120, right? The rest of the whole. Because the whole is what?
180.
180. And if I have 120 on top, I still need to get to 880 total solution, so I'll add that 60 mLs of diluent. Okay? Sloppy math. I'm sorry. What if I wanted this to be a 1/3 concentration? I'll actually switch it up so we don't even have any of the same solution numbers. I want this to be a 3/4 solution. 3/4. By doing cross multiply and divide, right?
No, I just did 0.75 of 180.
That doesn't help me with my math. So 3/4
Sorry, that's the way it
x
works in my head.
180 mLs cross multiply for x equals, what's 3 times 180?
360.
Okay, 2 is 360, so one more would
540.
be 540, yep. Right? 540 divided by 4
Should be 135.
should be 135. Is it April?
It is.
40.
Big money! Okay, so I have 135 mLs of concentrate. Okay, how many mLs do I need to have
45.
of diluent?
45.
45. And how'd you get that?
The 180 minus the 135.
Okay. We rarely have to do this though, but you need to know how it's done. So every blue, especially if you're on night shift and they have an order, the cafeteria won't mix up your Vivanex for you like they do for the day. And then also, if you're doing the Bacon solution, usually pharmacy will mix that during the day, but we don't have a pharmacist. Most hospitals don't at night. So that means that you have to mix your own solutions at night. Okay. Okay. Chapter 20. Most common insulin on the market is DNA insulin because it has fewer reactions than if I actually got some animal insulin and give it to myself, right? What's insulin for?
Blood sugar.
Blood sugar, right? Let's watch a little thing on insulin really quick so you guys can understand what insulin's all about.
Every cell in the human body needs energy to survive and do its different functions. If we're talking about a brain cell, it needs energy to keep stimulating other brain cells and sending on signals and messages messages. If it's a muscle cell, it needs energy to contract. They need energy just to do the basic functions of the cell. And the place that they get that energy from, or the primary source of that energy, is from glucose. Glucose, and glucose is a simple sugar. If you were to actually taste glucose, it would taste sweet. And glucose gets delivered to cells through the bloodstream. So this right here, I'm drawing some blood that's passing by a cell. Maybe the blood is going in that direction over there. And inside the blood, let me draw some small glucose molecules passing by. And so in an ideal situation, when a cell needs energy, glucose will enter the cell. So glucose will enter the cell. Unfortunately, it's not that simple for the great majority of cells in the human body. The glucose won't enter by itself. It needs the assistance of a hormone or a molecule called insulin. So let me label all of these. This right here is glucose, and it needs insulin. So let me draw insulin as these magenta molecules right over here. So that over there, that is insulin. Insulin. And the surface of these cells, they have insulin receptors on them. And I'm just drawing very simplified versions of them. Kind of a place where these magenta circles can attach, can bind. And what happens is in order for the glucose to be taken up by the cell, insulin has to kind of attach to these receptors, which unlocks the channels for glucose. In order for the glucose to go in, insulin has to bind to the insulin receptors. And then once that happens, then the glucose can be taken up by the cell. Now, unfortunately, things don't always work as planned, so let me draw a couple of scenarios here. So once again, let me draw my very simple version of a cell. And let me draw the bloodstream going by right over here. And then let me draw the glucose in the bloodstream. So I have my glucose floating by. And then I have my insulin receptors. My insulin receptors on the surface of a cell. Now, the first thing that could go wrong here is, what if the body does not produce insulin? Insulin is produced in the pancreas. What happens if the pancreas is not producing insulin properly? So no insulin. Well, in this situation, since there's nothing to bind to these receptors, the glucose channels won't be opened up, and the glucose will not be able to enter into the cell. And this situation is type 1 diabetes. Type 1 diabetes, where you've got glucose, so in theory you have energy, and you have properly functioning insulin receptors, but you just don't have insulin to kind of unlock the gates for the glucose to actually go into the cell. The other scenario that you can imagine happening, let me draw the cell again. So there's my cell, and let me draw the blood flowing past the cell. And once again, obviously, this is just one of trillions of cells in the human body. We have an estimated 10 to 100 trillion cells, so this is a very simple diagram that hopefully gets the point across. So once again, let me draw some glucose floating by. Let me draw some insulin receptors on the cell. So insulin receptor there, insulin receptor right over there. And let's say we even have some insulin. So our pancreas is producing insulin and putting it into our bloodstream, so it's there to be used. But a situation can arise where the receptors are not working properly, or we become insensitive or desensitized to insulin. So desensitized receptors. So in this situation, you have sometimes maybe it might be the insulin is hard to bind, or even if it does bind, it's not working properly, so the glucose will not enter the cell. And so in either one of I wrote desensitized. So in either one of these scenarios, let's just think in a very broad level, I'm not going to go into the details of the actual therapy for these diseases, of how it can be cured. Oh, and I didn't even name the second one. The second one right here, as you can imagine, if this up here is type 1 diabetes, this down here is type 2 diabetes. Type 2. Type 2 diabetes. Now, the simple way that, or I don't want to say it's necessarily simple, but the way that you can manage type 1 diabetes is you can inject insulin. The only problem here is, it's a big one though, is that there's no insulin in the bloodstream. Everything else is working properly. So over here, we can inject insulin. We can inject it. And then you'll have insulin to attach to the receptors, and then the glucose can be processed properly. Type 2 diabetes, there's kind of multiple lines of attack. One thing that you can do, there are actually drugs that attempt to kind of resensitize your insulin receptors. You can also do that with a combination of lifestyle changes that makes your body, I guess, more sensitized to sugar. Or you can even, if things get severe enough, you can add insulin, just like you would do in type 1 diabetes. And you can say, wait, I already have insulin here. Why would I add more insulin? Well, remember, we're not kind of, the cells can process insulin, but they're desensitized. They would need more insulin in order to kind of uptake the same amount of glucose. So if you add insulin, you could possibly have enough of a trigger that the glucose can actually be taken up. But there's multiple lines of attack here. And usually the first one are giving drugs that hopefully resensitize you or make you less desensitized to the actual insulin. And so the last thing I just want to think about a little bit is, well, what happens if you didn't do this? Well, there's two major problems here. Obviously, your cells can't function if it's not taking up glucose, so your cells will have no energy. And another problem, if you weren't to manage either one of these types of diabetes, is that sugar, once it gets to if it gets to high enough concentrations in the blood, it can actually cause a lot of damage. So sugar can cause damage to the body. So you don't want either of these things happening. You want your cells to have energy, and you don't want to have too much sugar flowing in your blood and causing damage to your body.
Okay. Diabetes made simple, right?
It's a really good website. Icon Academy stuff.
Yeah, Khan Academy, he does a lot of stuff for everything. Other organic chemistry, calculus, all kinds of stuff. If you're struggling with anything, Khan Academy, Khan. If you're struggling with anything science related, it's a really good place.
He does math on there too.
Yeah, he does math like calculus and things like that. So.
Spell that again.
Khan.
Okay.
He makes snap. He makes everything nice and simple.
You're on like 31 or something like that.
Okay. So there's not just one type of insulin, there's multiple types of insulin. Humalog is one of the fastest acting that there is. It acts within about 15 minutes. That way when you consume it, you take it 15 minutes before a meal, and when you consume a meal, you have insulin there ready to start using the sugar, okay? The bad thing is if I take it 15 minutes, plan on taking it 15 minutes prior to a meal, and I don't get to eat meal for an hour, what can happen?
You can have too much insulin.
Yeah, and I can have a hypoglycemic event because I've used up all the insulin that's in my bloodstream, and I need to supply it with more food or sugar, right? And if I'm not giving it that, then I can be hypoglycemic. Humalog is only for subcutaneous administration only. On the other end, we have long-acting, okay? And it's called analog or insulin-glargine human insulin. And we usually give it at bedtime or first thing in the morning. Sometimes, depending on the patient, we'll give it Q12 hours or Q24 hours. Most of the time, it's Q24 hours. And it's just what it does is it creates a basal rate. This kind of long-acting insulin that's in your bloodstream. So that, because you always have insulin in your bloodstream. That's part of the process of cellular energy. You have to have that constant insulin going. Sugar's going up and down normally, okay? When you're diabetic and you don't have a pancreas that's functioning correctly, then you don't have that same stores of insulin that comes and goes like the normal people do. So when we give you long-acting insulin, it works like your pancreas does. It has this nice basal rate. This regular just keeps your insulin level normal, okay? But when I eat what does my pancreas do? It increases my insulin output, so that I can take intake, right? It does it automatically. So that's what the bolus doses are for. They're the Humalog. So I'll give Lantus to last for 24 hours, so I have a normal, like I'm mimicking the pancreas, and then I give those bolus doses of Humalog to mimic my pancreas when I eat, and giving me a bolus dose of insulin, okay? So, if you can see what a pain that would be to, when you're a diabetic. I had a diabetic in the last class, and he was like, man, I was never taught any of this stuff. They just said, here, poke your finger and give yourself this amount of stuff, and like, he was pretty stoked.
So what are the price differences or the prices of these medications?
I'll be honest with you, I have no idea. I know they're expensive,
Yeah.
but I have no idea. I just because
Uh-huh.
insurance usually pays for it, access or whoever. There's usually some way for them to get it, just because of if you don't have your insulin, you can die. So usually they make ways for them to get their medications.
When I was working up in Moranti, I had a bunch of diabetics.
Yeah, and they have to monitor the glucose daily, and sometimes a meal by a meal. Just remember that insulin, very small dose, can go a long ways. So that's why when we give it, if I have to give 1 unit, which is like 0.01 of an ml, it has to be checked off by 2 nurses. 2 nurses have to look at that syringe and confirm that they have 1 unit of insulin, and then both of us sign off in the computer confirming that we both know that this is 1 unit of insulin, and we gave the patient 1 unit of insulin. Very, very careful. So, insulin label, 100 units per ml, right? The big R stands for regular, which is the generic name. There's Humulin regular, there's Novolin, there's multiple brand names, but if it has the big R, that means it's a regular insulin, whether it's Novolin or Humulin, okay? That's just brand names. And if you look underneath the generic names, it's right here on the bottom, regular. Concentration, this is a 100 units per ml, which is a universal concentration, or the U100 is the other sign that we have on there. So, every once in a while, we have different kinds of insulins, right? Lantus is actually a newer, the 24-hour insulin is a newer kind of medication. What was commonly given before was MPH. That was a longer acting. It didn't last as long as Lantus, so you would mix it with your regular insulin, which is a shorter acting insulin also, and you would mix the 2 of them and then give them together, so that way you get the immediate effect of the MPH, the regular, and then you would have the long lasting for that residual sugars and stuff like that of the digestive process in the MPH, okay? So that was the common to mix it, and we're going to do some of that today, okay? But just remember, always go from clear to cloudy, never from cloudy to clear. So that all makes sense when we do some of this hands-on. If I was to mix the 2, and I know that I need to give 30 units of NPH and 10 units of regular, okay, that's my order. I will inject the 30 units of air into the Novolin, the NPH first. I'm not going to touch my needle to anything, just put the air in there, okay? Then I'm going to inject my 10 units of air into my regular, the clear. Without pulling my needle out, I'll flip it over and draw back 10 units, okay? Make sure that you do this slowly, because you don't want, when you're doing, if it was just a single and you pulled a little bit too much, you could push some back into the vial and not be a big deal. And that's fine on the first, so I got my 10 units, but then I take this directly from here, clean this lid with alcohol again, because remember now it's got 30 units of air in it, and I flip it over and draw 30 units, back to the total of 40 units, right? 10 plus 30 equals 40. So I put 10 units first, because my order's for 10 units of regular, 30 units of NPH. So 10 units goes in, pulled in first on the syringe. 10 plus 30 is 40, so I need to make sure that I pull back to 40 to get that total dose, right? Does that make sense? And we'll do some of these. Okay, there is a question on your homework that says, what is the proper way to mix NPH and regular insulins? So just make sure you mention that you inject air into the NPH first, then inject your air into the regular. Withdraw your regular medication, and then withdraw your NPH medication. That is the proper order for doing mixing. Okay? In the hospital setting, we'll give regular before meals, but we check the glucose before they eat a meal. So if they have a glucose that's above 160, then we're going to treat that as before they eat. So then we check their glucose, and it's 255. How many units are they going to get?
They would get 4 units.
4 units of insulin. You see that? Because the range of 221 to 280 tells me that I'm going to give 4 units of insulin for that 255 that falls in that range.
And if it's greater than 400?
If it's greater than 400, then we hold the insulin and call the doctor, because he's going to give us a specific order. Give 12 units now, check glucose in 4 hours, and give another dose based on that. Okay. So that's why we call the doctor. And if it's less than, usually it's not on here, but most of the time you'll have a glucose greater than 400 or glucose less than 80. You'll get different orders. To say both of them will say call the MD. Is anybody here? You don't have to share if you don't want to. Is anybody in here diabetic? No. They also have insulin pumps. So here's a glucose glucometer. You can check your glucose. You poke your finger and get a little drop of blood, and then you use the glucometer strip that soaks up that blood and tests it using the glucometer. Or they have these insulin pumps that are loaded with Humalog cartridges. And it has a thing that plugs into your skin. It's like a little sub-Q needle, a little port that you plug in. And you tape it down, and it has a little hose that goes to your pump that you put. It looks like a pager.
And he just leaves it in his pocket.
Yeah, you leave it in your pocket.
One of my buddies is diabetic and has a pump.
And the way this is nice because this works exactly like your pancreas does. It lets out a low basal rate, and an endocrinologist helps you calculate that, so you don't just come up with these numbers all the time. And you have this basal rate that lets out that continuous insulin, just like your body would. And then, when it comes time to eat, you type in your carbs to the pump, and it will automatically calculate a dose, and you hit bolus now, and it gives you a bolus shot of insulin, and then you can eat. So you do it right there at the bits. And it can. Some of them require you to test your glucose, and some of them actually test your glucose for you. So they can test it and tell you what your glucose is. So, pretty dang cool. And they're starting to work on internal ones that don't require any, maintenance. So, artificial pancreas on the way. Just remember, U for abbreviation is not acceptable when it comes to insulin. You make sure you write unit. Because that can be considered a 0 if I have sloppy handwriting. And you guys saw my handwriting on my math, so you would see that a U could be easily mistaken for a 0, and that would be bad for a patient. So just remember, again, you always draw up the cloudy last. So air into the cloudy, air into the clear, draw the clear medication, draw the cloudy medication. Okay. Why do I do it in that order?
So you don't add air twice?
Right.
Or something?
If I add clear to cloudy on accident, that's no big deal. But if I add cloudy to clear on accident, when I'm putting messing the vials, if I get my vial if I have a clear vial that gets cloudy insulin in it, even the smallest amount, that clear vial is now trash. And we're talking about how expensive they are, right? So we don't want to have to throw it away. But if I get some clear accidentally into my cloudy, it's not that big of a deal. So that's why we are very careful the way we draw it up, because we don't wanna have to throw a vial out because we mixed it up wrong.
Is it because it's like long lasting and stuff like
Yeah,
that?
the difference in action,
Okay.
so. And this is just a reminder, if I had a order for 22 units of NPH and 18 units of regular, I'm gonna have a total dose of 40 milligrams of the combined. And we'll play with that here in just a little bit. Okay. So, quickly, we have about 15 minutes on each. There we go. Insulins. When you're done with everything, it's all trash. All your trash and needles go back in the bags they came with, okay? Okay, so we don't mix up our insulins. At the end of every row, I have your waste. It's a 30 ml vial, so when you mix it up, and we do some mixing and you need to do a new dose, you just squirt what you've mixed up in here, okay? That way you can have a new, you can use the same syringe for the next, okay? One per row there. All right.
Where do you get all this?
Oh, we just do, I ordered it. Okay. So the first one we do will be the one that you mix. But after that, since your powder will be all used up, you just draw it up in your syringe for the answer, okay? 4, 30. Okay. Okay, let's look at this. Let's do it. Okay. This is page 437. So get your books out that way you can read. So, it's 500 milligrams in the vial, and it says to prepare a solution, add 2 mLs of sterile water or 0.9 of sodium chloride for injection. It will provide a total volume of 2.2 mLs, which is 225 milligrams per ml, right? So go ahead and do that now. You have your fancy saline there. Your fake saline. What syringe are you going to use?
3 ml.
The 3 ml syringe. Go ahead and do what it tells you to do. Be careful, don't make your needle not sterile anymore. And don't poke yourself either. Last time I said that, we did this, he said, don't poke yourself. Ow! Mother, father. Who poked themselves? The girl lady. It wasn't me, it was the girl in the back. Sorry. Well, it was a sterile needle, so I didn't have to worry about it. So.
Yes.
Okay, so let's look at A. How much diluent must be added to the vial?
2.2.
2.2 or 2?
2.2.
You add 2.
Add 2.
Because what's my total volume going to be?
2.2.
2.2. Read the label. So what is the final concentration prepared? So it would be 500 milligrams and 2.2, or 225 milligrams per ml. Okay? That says that all on, it says it all on the label here. Okay? That's why if you bring your book out, if you have your book out on page 437, it's easy to read. If not, squint really hard and turn your neck.
Taz?
Yes.
Where's my,
What's that?
I don't have a choice.
Yeah, you do. 10 cc, 1 cc, 3 cc.
Is this one?
Yep. Just pop it open on the back.
Okay, thank you.
Some of the 3 cc syringes came in an actual enclosed plastic. You just pop the back of the plastic off, okay? Just like that, yeah.
You drop 2 mLs
You drop 2 mLs from your saline.
from. Do you air it or no?
Put your air in it first, yes.
Okay.
What's that? 2 mLs of air in the saline first.
Okay.
Draw out 2 mLs of fluid. And then put that 2 mLs in with your fancy mixing stuff. Put air into your saline first, yep.
2, right?
2 mLs.
You just pull it straight
I
out.
just,
Oh, you flunked.
I did.
You flunked.
Taz,
Okay.
make it go in.
Pull out the 2.
Yes.
Okay. Do you need my saline?
Nope.
She's got hers.
She's got her own. Everybody has their own stuff. Yes, you want to clean it with the alcohol swab first.
You don't fill it. You don't fill it fast.
So then you draw. Make sure you try not to hold the plunger because that plunger's sterile. You hold it just by the flanges only of the syringe and flanges of the plunger when you're drawing.
And then I draw
2
2.
mLs.
Okay.
So once you put the air in, can you just draw it right out?
Flip it over and draw it right out. Make sure there's no air in your syringe.
I can't get this thing.
Now flip it over and then start drawing. What do you mean you can't get it off? Just pull it straight off.
Okay. You do it perfect. Mine doesn't.
Yep,
Yeah.
put it in there and mix it up. It should change colors if you did it right. Most of them are.
Turn to clear.
That one, oh, those will turn to clear. Some of them will turn yellow and some will turn clear.
Okay, then what?
Okay, so now what's our concentration we have? 225 milligrams, right, per ml. The order's for 250, so how many mLs are we going to give? to do the math, right? Order for 250 milligrams. What's my available dosage? What's my available strength?
500 milligrams. Oh, sorry.
What's the concentration?
The concentration on here is
225 milligrams. 225 milligrams per milliliter.
Mm-hmm.
so 1.250. That would be 225.
Thanks, Rod.
1.1 ml.
Okay. So, what's your syringe gonna look like?
I capped it.
It comes under.
I really don't know. I'm gonna need a stick to find that out.
It's hard to see on there. One.
Yeah.
One.
Yeah, I don't even. I don't even cut
Wait a
myself.
minute. Oh, you already capped
Yeah, I
it?
capped it.
Smart
Full
pants.
bodily props.
So don't cap your needles until you need it. Yeah, don't worry about trying to pull that safety guard off. You can they'll twist off, but little hack that we use in the nursing, like you can actually twist the needle off.
Oh, really?
Like you can take that top thing and break it and twist ball twist it.
Oh, yeah, I see.
But you don't want to.
Yeah.
Not that that ever's been done before.
No, not at all.
So. Okay. So I did the math on that one. Now you guys have all mixed once. You have some solution. Let's do the next one. Okay. Okay. I want you guys to read that.
So we're done with this part now?
You need to save your syringe and your medication because you're going to draw it up and show me
Oh.
what the answer is. Just recap your needle using the scoop method. Don't do it. Don't do that. Don't do that.
Well, if I recap, I'm not gonna be able to use it.
No, you recap it with the plastic.
The plastic cap was on it.
Oh, you don't have to put the orange on.
Don't put the orange on it because once you put the orange on it, the needle's done.
I think it's materialistic.
So did I?
Okay. Well,
Full body.
so this is what we'll do. For those that have already capped it up using the awesome safety devices that are built in, we just need to make sure that you know the math. Okay. So looking at this, how many milliliters am I going to administer for a dose of 165 milligrams?
500 milligrams.
What page is that on?
438.
For how many milligrams? 165.
Just the 160. And what do you want now? Tell me again.
The dose is ordered is 165 milligrams. And using the label, tell me how many mLs I'm going to give for that dose.
1.3.
Not 1.3.
It'll be like 2 point.
Keep your answer to yourself
Like,
until I show it. Those that have syringes that are still usable, go ahead and draw up the dose.
Out of our mix.
Yep, out of your mixed stuff already. We're going to pretend that you mixed a new vial. Everybody got an answer so far? What's my concentration? It's not like the other Sliema draw we looked at that gave us an actual per ml, so what do we have to know? It's under this. It's under the one of the bullet points here. It's under this bullet point. Don't pay any attention to this. Monobasic sodium phosphate anhydrous, dibasic sodium phosphate. That doesn't do us any good. There's a specific though. Each 8 mLs contains methylprednisolone sodium succinate equivalent to methylprednisolone 500 milligrams. So 500 milligrams is in each 8 mL. So what's my concentration? 500 per 8. Yeah, so that's what we can use to do our math. Okay? For a 165 milligram dose.
And then just draw it up?
Yep, draw it up.
So if we capitalize, we don't have to do anything?
Yeah, you just write, you just make sure that your math looks very similar to that bottom one.
Okay, I guess I don't have enough room.
Oh. Or your syringe looks like this with 2.6 mLs.
Yeah, my syringe don't look
Where
like that.
did you get the 165?
The 165 is the dose.
Okay,
That's the order.
That's
that
the
was
order.
the order?
Yep.
Okay.
Okay.
My syringe doesn't look like that one.
Doesn't look like my syringe.
No.
Is a 3 ml syringe though?
Yeah, 3cc.
You should have.
Enough fluid.
Oh, but you didn't put it because we only put 2.2 in, right? With the last one to have a.
How much you want me to get?
Because you should have 3 mLs. Did you squirt it out? Oh, it was per 2.2. Well, you added 2 mLs for a 2.2 solution. My apologies. Don't give me that look. Hey, at least you got some practice with that syringe, right?
Yeah.
It's better than just doing math. If I figured some hands-on would be
Making me
good.
look like I'm doing it wrong.
Okay, let's do one more.
Are we squirting it back in?
Squirt it back in.
Just watch every note, squirt it back in.
No problem.
Let's look at number 3. On 438. Okay.
On what page?
438, number 3. 375 milligrams Q6 hours. Okay, so what's A? How much diluent must be added to the vial for administration? First line there on the reading that you have to turn your head for.
1 gram?
1 gram is the medication. How much diluent? 3.5 mLs, right?
Yes.
That's A. What is the final concentration if I add 3.5 mLs? 250 milligrams per ml. So how many milliliters am I going to administer? Do the math and draw it up.
Will I be equal to?
OMG.
Just asking.
I don't know, you tell
Yes.
me. If you have a 2 ml solution from the first dose they made, and you have 250 milligrams per 1 ml, what does your math tell you?
That you can.
Uh-oh.
You should be able to.
My needle's stuck in my cat.
Well, don't do that. Well, then take off the safety. Take off the safety.
No,
You're stuck in
it's
it.
stuck
No,
in it.
right, so if you take off the orange thing off your syringe,
Oh, okay.
big money, no whammies. You got it. Okay, so how much do you need?
375.
1.5.
Or 250. 375.
So you're gonna have to do that one.
Always do math over 5 by 100, which is 375.
Dimensional analysis, 375 times 1 divided by 250 gets us 1.5 mLs. So that's how your syringe should look, 1.5, minus the bubbles. Shh, don't tell me. 1.5, okay?
It's 2 or more.
We're gonna do some insulin next for time reasons. Okay. Okay, put your mixing stuff back in that bag, needles and everything, and get your other bag out. You had a big.
You want sharps in the appropriate containers?
Put your sharps. We'll take care of the sharps here. So just put your sharps.
Are we done with this needle? Are we done with this?
Yeah, you're done with the needle. Don't poke yourself. You can break it. You can put the safety on now for the ones that you use for the mixing meds.
Never use your finger to recap a needle.
I do it every time. No, I'm just kidding. Yeah, don't use your finger. All right. Okay. So now we have some orders in front of us. And you have an insulin syringes and insulin vials. You have different vials in your little bag. The order is for 35 units of regular. So find the right vial.
What page were you on?
Oh, I apologize. 484.
What page?
484. Just a little cool thing to look at though. Because Lantus is long acting and it's given in different doses, it has a different shaped bottle than all other insulins. It's usually long and narrow versus short and stubby.
My regulars and my MPHs are like the same.
Yeah, they're supposed to be. Lantus is different.
Okay, Atlantis is
So just to give you an idea. They do that, the manufacturer does that to avoid medication errors. So, alright. So the order's for 35 units. Let's drop 35 units.
And how much is?
good. The regular?
Of what is the dose for? What's it say?
35 units.
35 units of what?
Regular.
Regular. So what do we put in first?
35 units of air.
35 units of air. You'll find that you have less bubbles when you put air in too, and you draw a little bit slower.
That was great.
Why are bubbles important to clear from, especially in insulin syringes?
Air pockets can kill you.
Well, air pockets will
Wait, we're
displace
supposed to do
volume.
35?
What's that?
35?
35. Don't.
These are multiple of twos.
Yeah, that was my comment. Yeah.
Correct.
Right.
Because We got U100, 1 ml syringes. Well, that's good to know. I thought we had 50 units. Okay, so draw up 34 for me then.
I put my half back.
If you have it.
I just guessed in the middle.
Yeah. So the syringe, half of you guys, I bet you will have this kind of syringe that does it out to the single unit. It's a 50 unit syringe. If you have a 100 unit syringe, then I want you to drop 34 units. But in real life, what would I do in that situation? If I had to order for 35 units?
34, round down.
Nope.
Round down.
36.
Go get a different syringe. Because insulin is exact. We don't round insulin. Okay?
Put that into the still.
But so
34 of this one, and then draw it, and then add it.
So this is just, right now we're just doing the one, we're gonna do one of each. We're gonna do one of each. Okay. Then, so go ahead and take your regular and put it back into the regular. This is not what you would do in real life, but just so we can save it, be ready for the next thing we're gonna do. Number 2. Order is for 56 units, so like people with 100 unit syringes are going to be happy. 56 units of what kind of insulin?
NPH.
NPH. So what are you going to draw up?
56 units.
56 units of NPH. So draw that up so you can practice that. Not to use, don't use that one. Use your actual insulin syringe. NPH needs to be swirled up. That stuff will settle. That's part of the insulin.
It's supposed to be cloudy?
Yep. NPH is cloudy. Most long-acting insulins are cloudy. Lantus is cloudy also.
What do you say?
Okay, so how many units are you drawing up and what time?
56
and
NPH.
NPH.
We do 56. You do 56 units of air in, and then draw back 56 units of NPH. Okay. You get your 56 units. Once you get your 56 units, you can push it back in. This is just practice. Give you some hands-on business, because now we're getting to the real deal now. Once everybody's got it drawn up. Okay. Number 3. Order Humulin R U100 18 units and Humulin N U100 40 units. How are we going to do this?
$40 units first. Cloudy.
So 40 units of air into the cloudy first, right? 40 of units into the cloudy.
Take 40 back out?
Nope. 40 units of air. And don't touch your needle. Has to come in from the top like this, with nothing touching the insulin. 40 units of air without touching the cloudy insulin. Then 18 units of air, right? Into the, which one?
Regular.
The regular, right? You put that 18 units in, with it being upright like this, turn it over, and draw your 18 units right back out. Oh. Okay. 18 units. Then I can go back to my cloudy, and don't push anything in, I'm going to start drawing the cloudy, right?
So it should be at like 58,
Not just like, you should be exactly 58.
Okay.
Pretty sure. So I don't have 58 on my syringe because I have a U50 syringe, or a 50 syringe, 50 unit syringe. So I can't do that. But do I push anything anywhere? No, I got to pull it back exactly to 58 the first time.
So go nice and slow.
Nice and slow and be patient with it. Okay. So what is the total volume we'll have in your syringe? 58. Then you can take it and inject it into this waste vial. Okay, and we're going to do one more of those. And you guys are going to walk me through the experience now.
So you said we dump the 58 back into her, oh, I don't know what's going on.
Number 16 on 488. Walk me through the steps. What am I going to do first? The order is Novolin R 40 units and Novolin N 10 units.
Air 10.
10 of air where? Cloudy first, which is
The NPH.
MPH. Good. So, put my 10 of air into my MPH. Tell me what to do next. Do I inject it upright. I don't flip that vial over, right? I don't want to touch my needle with anything at all right now.
And then 40 air.
And then 40 air into where?
Regular.
Then what?
Draw 40 air.
So I put the 40 of air in, and then what do I do?
Take 40 out.
Take 40 out.
Take 40 out immediately. Okay. So good so far.
And then you take 10 out of the cloudy. Right?
Okay. And then draw out to 10. Scared. Slow.
Are you mocking us?
No, I'm being serious. Okay. So how much total do I have in my syringe?
50.
50. I got 50 in my syringe. There it is.
Into the waste basket.
Right? And then inject it, the mixed insulin into the waste basket.
And then this one's still waste.
Okay?
Thank you.
All right. Is there any questions?
No.
All right.
Maybe you already told us this.
Yes.
So sometimes the order will just be for regular and sometimes it will be just for NPH. Okay, so why is that and what?
Different
like,
dosing times.
specific?
Different dosing times. But if I have the order together, what if they wrote two separate orders for the same time? Can I mix them? You can mix it. That's your nursing discretion. But I'll tell you what I do in the hospital, because the only two that you mix is regular and NPH. So most of the time I'll just give it as 2 injections anyway. Just to decrease my possibility of contaminating one or the other. It's a 30 gauge needle, and when you're cleaning with the alcohol in the back of the arm, if you scrub it really good, 99% of the time you'll give it and they'll say, hey, did you give that? So if you overstimulate the skin first when you scrub it with the alcohol swab, they won't even feel you do the injection. So what is it?
Just scrub really hard.
So just give it a good scrub, which they need it anyways, so you can have a good clean site. Don't just wipe the site once. If you give it a little scrub. So all the needles, you can put them at the end of your table. Just put everything else in your bags.
We didn't even use the 10s.
Yeah, we didn't. 10 cc syringe put in there. The waste basket put at the end. Okay, any other questions before I turn it off from the other class?